Go ahead, Jackie.
All right. Welcome, everybody. My name is Jackie Harvey, and I'm the presenter for this evening, and I hope that you're in the right spot. We're talking about women in hormone health. Before we get started, though, I'd like to thank Dr. David and Sherry for putting together the Building Strength webinar series and for their commitment that they have to presenting really good quality webinars every week. They hope to empower people with the wisdom needed to make intelligent decisions and how to use their own minds and bodies and live long, healthy, meaningful lives. And we share that vision with them. And so I want to just express my gratitude at being invited and just to say I'm thrilled to be here this evening. All right, we're going to deal with women and their hormone health issues. And tonight I'm exclusively dealing with women and hormone health issues. On March the 31st, which is in 2 weeks, I will be talking about men and their hormone health issues. At the end of the presentation, there'll be an opportunity to ask questions. You'll be able to type them in, and they come directly to me, and I'd be more than glad to spend some time at the end answering your questions. I want to just note that men do have hormones too, and even though sometimes they're not aware of that. So addressing men's hormone health will be a priority on the 31st. And I may occasionally go back and forth with that tonight, but for the most part we'll deal with it exclusively on the 31st. So tonight I want to primarily address the issues related to estrogen and progesterone imbalance. And Dr. John Lee, who was a mentor of mine, called that estrogen dominance. Dr. Lee endorsed what I do. He really believed that what we had to offer at Help for Hormones was important to everybody. He told me once that if women would go on the program that we outlined, that 80% of the women would have a breast cancer prevention program, would prevent 80% of breast cancer from happening for those women that embarked on it. And that was enough motivation for me to certainly continue to share the information like I'm sharing this evening. So let's get going. We're talking about 4 areas that are related to hormone health. We'll talk about how our body makes hormones. We call that the biosynthetic pathway to hormone production. We're going to talk about what happens when hormones go out of balance, and specifically we'll be identifying estrogen dominance. We'll talk a little bit about the historical perspective of the options that have been commonly offered by physicians in North America, and they are hormone replacement therapy called HRT, estrogen replacement therapy, which is estrogen alone, ERT, and certainly the birth control pill. And if you understand under these 3 options that women are being medicated for decades. Then we will address a natural solution to hormones out of balance. My goal here is to keep you spellbound and captivated for the next hour or so. But know that our goal, balanced hormones, I believe is an important key to optimum health and wellness. In fact, I don't believe that we can be healthy and well without balancing our hormones first. So we acknowledge that we need to have education, we need to have tools, in order to do this, and tonight's call will be, I hope, for everyone who's attending, a part of that. My goal is to talk initially about how the body makes hormones. We call that Hormones 101, and so I want to start by identifying the pathway that in which sex steroid hormones are produced. So in talking about that pathway, we have to start with cholesterol. Cholesterol is the main building block for all the hormones that our body makes, and that might come as a surprise to some of you. I personally believe that cholesterol is getting a bad rap. Having too much cholesterol can in fact be a risk for heart disease. We hear a lot about that, but it's also dangerous to have too little cholesterol. In fact, without adequate cholesterol, you and I are not able to live. We can't produce vitamin D. We can't produce our sex steroid hormones, estrogen, testosterone, and progesterone. We can't produce DHEA. We can't produce cortisol, stress hormone. So cholesterol is really essential in our body. It's also used to make the myelin sheath the fatty coating that surrounds our nerves in the spinal cord and the brain. And studies have shown that people with very low cholesterol levels are likely to develop cancer or to suffer from mental illness. Now, Dr. David Brownstein believes that in addition to that, people with very low cholesterol levels just may not have adequate hormone levels. Because cholesterol is a critical component in the production of steroid hormones, suggests that if your cholesterol levels are declining and there's nothing else in your health to reveal why that would have a negative impact on your health, Dr. Brownstein puts forth the suggestion that perhaps your cholesterol is elevating, going too high, because your hormone levels are dropping too low. So lower cholesterol or lowering cholesterol with statin drugs may not be exactly what women and men who have low sex steroid hormones may be looking for. So I think Dr. Brownstein might be on the right track. Elevated cholesterol indicates that the body is struggling to produce hormones. So test your hormone levels. See if there actually is a deficiency before you move out on cholesterol. So what might be a better way to deal with our cholesterol? Well, in this little vignette, weightlifting can help to lower your cholesterol. So load up your fork with veggies and lift it to your mouth. Do 3 sets of 15 reps daily. Interestingly enough, we will be talking a little bit about nutrition, and I concur with this little piece of information in this box. I think that one of the things that we need to look at is maybe not achieving such low cholesterol levels that our body can't produce hormones. All right, let's move on. From cholesterol, our body produces pregnenolone. Now, pregnenolone is a precursor hormone, and it's perhaps only a catalyst. It appears that when we give the body supplemental pregnenolone, it doesn't necessarily improve the hormones down the pathway. So, you know, in truth, there's not been really very many studies on this hormone. But we do know that in the pathway from pregnenolone, progesterone is produced. Now, progesterone it gets its name because it is the progestation hormone, the hormone that is needed to keep a pregnancy. We all know women who have begun a pregnancy and they've not been able to keep that pregnancy. They spontaneously abort the pregnancy in the first trimester of that pregnancy. That will often be attributed to low progesterone. Again, at the other end of pregnancy, we know that by the last trimester, a woman's body is producing, and it goes from about 20 milligrams of progesterone per day up to 400 milligrams at the end of her pregnancy. 300 to 400 milligrams of progesterone daily is not considered unusual. If the body's progesterone stores are not high enough, then what we tend to see is postpartum depression at the end of a pregnancy. And we've learned from doctors like Katarina Dalton that postpartum depression can largely be placed at the feet of low progesterone. We also understand that if progesterone levels drop part way in the pregnancy or before the last trimester, that it will likely produce a preterm baby, a baby that's premature. So progesterone for women is a very important hormone. Progesterone is found in men too. We'll talk about that a little bit more on the 31st. But we know that the human body requires progesterone, and this is the reason, because progesterone manufactures or is the precursor for cortisol. Now, cortisol is our stress hormone, and I probably should ask everyone listening to this presentation, what's your stress level like? Do you have any stress in your life? Dr. Lee believed that stress was the main reason why women's hormones went out of balance, and if you understand the relationship that you're looking at here, if it is true that cortisol requires progesterone to be in place, and if for any reason progesterone stores dropped in a woman's body, that would make it more difficult for a woman to produce enough cortisol just to keep stress on an even keel in her body. think of cortisol as a backup energy system. It's sort of like batteries in that back up your electronics when the power goes out. You can't keep using them to give you full power or they'll wear out. You'll also lose the source of energy in the end. In other words, the adrenal glands will fail. And I think that the analogy is correct. If we initially are under stress, our body will overproduce cortisol just to keep us afloat. But what we will ultimately do then is burn out our adrenal glands, and then we won't be producing as much cortisol. And that will always put a stress on our progesterone stores. In fact, it's one of the 3 reasons why progesterone could be low in North American women today. Now, from progesterone is produced testosterone, androstenedione and testosterone, which are converted to each other. Testosterone is the strongest of the male sex hormones or androgens, but again, this procedure or pathway also is found in women. And the majority of this, progesterone to androstenedione to testosterone, would account for, again, low testosterone levels in some women if their progesterone stores aren't adequate. Dr. Lee has often said that it is not likely testosterone that's the libido hormone, it is progesterone. And this is, when you're looking at this pathway, this is what outlines that. You know, testosterone does play a dramatic role in most or in many aspects of our physiology. Certainly our quality of life, our sexual satisfaction. Certainly it plays a role in bone density. But our overall sense of well-being and our body composition are determined by having an adequate, and that's a good word, an adequate amount of testosterone. And testosterone certainly does activate the sexual circuits in the brain, but I have found through saliva testing that the majority of North American women are not deficient in testosterone. They are, in fact, deficient in progesterone. So I suspect that Dr. Lee was correct in his assumption that libido issues are not about low testosterone, but likely about low progesterone. Well, from testosterone and from androstenedione, all the estrogens in our body are made. And the estrogen is a family. It's a general term that's used to refer to a group of what I guess are mainly considered female hormones, although we now know that men have estrogen as well, and in fact a man at 50 and a woman at 50, he will have higher estrogen levels than she does. But there are 3 principal estrogens, E1, E2, and E3, that are found in our body. We'll talk about a little bit more about each of those in just a moment. So there are 3 ways that our body makes estrogen. Even though the chart shows a nice flow, the first way that our body makes estrogen is in our ovaries. You know, in order for the ovaries to produce estrogen, a woman has to be ovulating. So she would be menstruating and ovulating. This is for women that are upwards to mid-40s to even mid-50s that are still menstruating and ovulating. The adrenal glands are the secondary, or what I call supplementary system that is in place for production of estrogen in a woman's body. But what we're finding happening, again, it's those same adrenals that are pumping out cortisol to help women in North America with all the stress that they're undergoing. And so for some of us, our adrenals may not be able to produce that little bit of estrogen that's required to supplement either as we go into menopause or to supplement the ovaries. Fortunately, there's a third way, and that is in our adipose tissue or our fat tissue. Nice way of saying fat tissue is adipose tissue in our body. Our fat tissue is actually able to take androstenedione, bring it into the fat cell, and convert it there to estrogen. That probably wasn't the best news that you've ever heard, but just recognize that I've noticed, and I hope you have too, that women in North America are gaining weight as they age. So that means that the majority of North American women, if they have gained 10 pounds excess body fat from the time they were in their mid-20s to the time they hit menopause, they will likely have more than enough ability to produce estrogen in that 10 pounds of excess body fat. In fact, Dr. Lee said that we needed to have 10 to 15 pounds excess body fat on our bodies when we hit menopause, so that when our ovaries aren't functioning at a high level and our adrenals struggle to produce estrogen, that we would have another mechanism or a way of producing estrogen that was adequate, and that is in our body fat. So you want to ask yourself, if you're sitting there tonight wondering, do you have 10 or 15 pounds excess body fat on your body? And if you do, it's likely that Dr. Lee was correct, that you will never need to supplement with excess estrogen. Of course, you can find this out doing a saliva test, and we'll talk about that in just a moment as well. The 3 estrogens then, let's review those. And they are produced through enzymatic activity. E1 estrogen is the main estrogen that's produced in our body fat under the influence of aromatase enzymes. So our body takes androstenedione or testosterone and converts it to estrogen. And again, all of that activity takes place in our fat cells. So this is similar to the conversion that takes place in men's body as well. And the fat cells where this takes place, you'll be interested to know, are usually located around our midsection. So as we gain in girth around our middles, that is the fat that is capable of producing estrogen. In premenopausal women, estrone levels are generally parallel to those of estradiol, the next estrogen that I'll show you. But after menopause, again, these estrone levels increase, and probably due to the fact that we're gaining weight and we have more of an ability to produce this form of estrogen. Estradiol is the strongest estrogen that our body makes. It's produced again from testosterone or is produced in our ovaries. And it is considered strong and actually one of the main causes for cancer. But interestingly enough, and I just previously mentioned that E1 estrogen and E2 estrogen go back and forth between each other. And so when we produce estrone in our fat cells, it can convert to estradiol, which is very potent, and often E2 estrogen is seen as the cancer-causing estrogen. But estrogen levels, in particular estradiol levels, fall after menopause, and certainly after a hysterectomy when the ovaries are removed. So estradiol production diminishes dramatically about the same time that estrone starts to increase in our bodies. Well, there is another form of estrogen. It's called estriol. It's a very weak form of estrogen. It has about a half the life of estriol and has been shown to be between 3 and 64 minutes in its life expectancy. Now, its weakness may be its strength, but research, according to Dr. Eldridge Taylor, who's a medical doctor, and actually is an OBGYN, his research suggests that estriol has benefits for bone density, heart health, MS, and postmenopausal urinary tract health. And so E3 estrogen is often, because it's also in the largest amount in our body, about 80% of our estrogen is E3 estrogen. Only 20% is divided between E1 and E2. E3 is the estrogen that also escalates during a pregnancy. And so we consider E3 estrogen a protective estrogen. And Dr. Lee talked in his book about using E3 estrogen as the primary form of estrogen for supplementation. And again, because it does not go back up the pathway and become E1 or E2, which could be cancer causing. So, I think research is going to find that if women need to supplement with estrogen, that E3 estrogen is a safer way to supplement. Now, we've talked about estrogen and the amounts of estrogen and how it's formed. Interesting to note that I believe that the majority of North American women do not have low levels of estrogen, nor are they deficient. You would have to look at a woman and see if she is slender and kind of frail. She would not have a lot of body fat, and then we might be looking at a woman with low estrogen. And if you look at yourself in the mirror, if that describes you, then there is a possibility that you might be one of the 10% who might need some estrogen supplementation. But for women who have an adequate amount of body fat, who have perhaps 10 to 15 pounds excess weight on them since menopause, then those women, or even adding weight into their 30s and 40s and 50s, these would not be women who necessarily need supplemental estrogen. What is the problem then that is contributing to hormones out of balance? Well, there always is and requires a balance between progesterone and estrogen. And there are only two ways that our body produces progesterone. One is through the ovaries. Again, because progesterone is the progestation hormone, when the egg leaves the ovary, the little nest it leaves from is called the corpus luteum. That produces progesterone. In order to have progesterone being produced for women who are menstruating, they have to be ovulating. Now, again, there's a secondary mechanism, and that is through the adrenal cortex. The adrenals will produce a little bit of supplemental progesterone if it's required, particularly for menopausal women. However, I have found that menopausal women, women that are aging, are under tremendous stress. Their adrenals are focused on producing cortisol and are not able to focus on the production of progesterone. And although the brain produces small amounts of progesterone, our fat tissue, which is in quite a bit of a larger amount in our body than the size of our brain, our adipose tissue is not able to make progesterone. So many of us are left in progesterone deficient states. What does progesterone do? Well, Dr. Taylor again suggests that progesterone slows normal and abnormal cell growth while balancing the effects of estrogen. In fact, when there is not an adequate amount of progesterone available to match up with the amount of estrogen in the body, we call that unopposed estrogen. And that sets us up for things like cancer. A study done at Johns Hopkins Medical School revealed that women with progesterone deficiency were 5.4 times likely to have breast cancer prior to menopause. And this study clearly illustrates that breast cancer is associated with progesterone deficiencies. Now here, we're talking about not women in menopause, women who are still menstruating, and we'll get to more of this later. Now, I want to just assure you that Provera, the drug that was provided to balance with estrogen in HRT, is not progesterone. Provera, or medroxyprogesterone acetate, is a synthetic, and it does not do the same things as progesterone does, and it has lots of problems. It actually increases the risk of breast cancer, partly because this synthetic progestin comes into the receptor site and it blocks the receptor site. So your own body's progesterone that you're making cannot get in. And so if you look at taking a progestin, it's going to diminish the amount of progesterone that is actually in your body's cells and will put you at risk as if you almost didn't have any. So all of these risks, or all of these problems, can evolve as a result of low progesterone, but progesterone receptor sites that are filled with synthetic progestins. Now, women in all of their life stages are producing sex steroid hormones. They are supposed to be present in optimal amounts. And at all stages, we've now seen they can become imbalanced. So here are the 4 stages as we look at it of a woman's life. And if you look at adolescence and then premenopause, perimenopause, and menopause, you'll notice I don't have the term postmenopausal. And it was interesting, Dr. Geraldine Pryor, who's an endocrinologist at the University of British Columbia in Canada, I first read about her in John Lee's book, and then she later contacted me, and we had a couple of opportunities to dialogue together and had a great time. But her comment is that there is no stage after menopause, that when a woman's menstrual cycle stops, 12 consecutive months, she becomes menopausal, and there's nothing after menopause. So if you're postmenopausal, you're dead. So I hope you're chuckling over that because we either laugh or cry over these life stages and all the problems that we have. And when I'm looking at this, I see everything has the word menopause except for adolescence. So basically, after adolescence, all of our life points towards menopause. And if you want to even look further, the word men is in each one of these words after menopause as well. Might be significant. All right, let's take a look at hormone levels, estrogen levels, as we head through these 4 stages of a woman's life. You'll notice, and I'm going to resurrect my pointer here, you'll notice that in the teen years, estrogen levels fluctuate fairly dramatically, and they're not stable. They stabilize pretty much through premenopause. This would be the age of the 20 to 30-year-olds. And then in perimenopause, maybe starting around age 45, they start to really dramatically fluctuate and then level out at menopause. Now this, Dr. Pryor showed, is normal for majority of women. I want to identify what's going on by using a menstrual cycle. So if you would like to draw on a piece of paper with me while I do this, we're going to outline a menstrual cycle. So draw the diagram like a large H. Day 1 on the left, day 28. We're going to use a 28-day menstrual cycle, not because that's normal. A normal menstrual cycle can be anywhere from 24 days up to 32 days. Halfway in the menstrual cycle, a woman ovulates, somewhere between day 12, 14, 15. Estrogen begins to be formed after a week at the beginning of the first menstrual cycle. From the beginning of the menstrual cycle, 7 days in, a woman sheds the lining from the previous cycle. And then estrogen starts to elevate. It reaches its peak about ovulation, and then if there is no fertilized egg implanted, the estrogen level just normally falls. Progesterone, on the other hand, does not become manufactured until ovulation. So remember, where the egg leaves the ovary, the little nest it leaves from, that's what produces the progesterone. So progesterone peaks about day 19 to day 21 in the menstrual cycle. And then again, if the body sends the signal to the brain that there's no fertilized egg implanted, then the progesterone level falls. In order to have a normal menstrual cycle, a woman has to have the rise of estrogen and the fall of estrogen, the rise of progesterone and the fall of progesterone in a normal sequence. If one of those is missing, she will not have a normal menstrual cycle. In other words, progesterone, if it is not present in an adequate amount, then her menstrual cycle could extend and become longer. Dr. Geraldine Pryor actually found out that there were women at the University of British Columbia who were not ovulating every single cycle. When a woman doesn't ovulate, her progesterone level then remains low all the way through the cycle. When that happens, that's term, Dr. Pryor called it estrogen excess, because estrogen was way high over the amount and excessive over the amount of progesterone that was there. She's now working on another study to show or to determine if women can actually tell when they ovulate or not. She figures that this is important because ovulation disturbances are common for women in their 20s at the beginning of their cycles and at the end of their reproductive cycle. And so she's trying to help women, or by doing the study, to determine whether or not we can actually tell. Physicians up till now have not been able to really predict that. But what she says is this, that PMS, and I'll just go back here for a minute. She started to observe that in the last 8 to 7 days prior to the next menstrual cycle, she noticed that these women with elevated estrogen, low progesterone, because they weren't ovulating in that particular cycle, were experiencing PMS. So today, she says all women, no exceptions, who develop PMS are going to be experiencing this because of estrogen dominance, or what she calls estrogen excess. So understand that if we have young women in their teens and up to their 20s who are suffering from symptoms of PMS, it would be advisable to find out what their hormones are doing. and resolve the issues behind their hormonal fluctuations. Do you know anybody who suffers from foggy thinking, irritability, or memory loss? Some of you will likely be saying, I don't remember. Foggy thinking, irritability, and memory loss are all part and parcel of a symptom of estrogen dominance. There is no question that elevating estrogen levels in the presence of not enough progesterone will be contributing factors to this. The Women's Health Initiative study, which is ongoingly doing research, has come out with the WIM study, that is the memory study. And the memory study shows that if you elevate a woman's estrogen level beyond what it should be for her age and stage, it starts to create memory issues. It showed that HRT and estrogen alone both increased a woman's risk for Alzheimer's and dementia. Now, we've also learned that the largest number of receptor sites for progesterone are located in our brain. So that means that if you are suffering from foggy thinking, irritability, and memory loss, you want to check out what your progesterone levels are and restore progesterone levels to what they should be normally. And for most women, that will go a long way towards resolving the issue. Now, certainly, women who are suffering from low-functioning thyroid will also have some of these characteristics and symptoms, and we'll talk about that in just a little bit. Fibrocystic breasts, uterine fibroids, and ovarian cysts are all symptoms that are connected to estrogen dominance. I want you to think about the role of estrogen in a woman's body. It is to cause cells to grow and to multiply and divide. Now let's look at what are cysts. Aren't they just cells that have experienced cell proliferation where they grow and they multiply and they divide? We believe that cells grow and multiply and divide under the influence of too much estrogen, unopposed or without adequate progesterone. So fibrocystic breast disease, uterine fibroids, and ovarian cysts are all stimulated by estrogen. Now, there is no question that there may be other things that come into play. Dr. Fleckis, for instance, of the iodine group, says that breast tissue has an affinity for iodine. So iodine deficiency can be another contributing factor to fibrocystic breast disease. So checking out whether your iodine stores or your progesterone stores are too low, finding out if your estrogen is too high would all be good things to do to determine this symptom related to estrogen dominance. With regards to depression, we know that women experience depression roughly twice at the rate of men. And so we have to believe that there's some sort of hormone connection. The balance of depression may be shifting to women younger and younger. And we're seeing a menstrual cycle shift in women younger to younger. We're seeing more anovulatory cycles in women younger to younger. And we have to suspect we're seeing lower progesterone levels in women younger and younger. And again, I alluded to this before, the German study that showed the largest number of receptors for progesterone are located in the brain. If a woman is suffering from low progesterone, she could be at risk for depression and anxiety attacks. Decreased sex drive is another issue, and again, I alluded to it. Dr. Lee says that more than likely a decreased libido is not attributed to low testosterone. For when we test women, they usually have normal or even high testosterone levels. Testosterone, by the way, is influenced by insulin or by sugar. So if a woman is over-consuming carbs, is on the pathway to becoming insulin resistant, she'll be producing a high amount of testosterone. And she'll observe that by her facial hair increasing, her waist thickening, and, you know, sometimes the hair on her head will be leaving as well. She'll be having thinning hair. These are symptoms of elevated testosterone in the face of insulin resistance or the beginning of insulin resistance. So again, we come back to what Dr. Lee said, that he believed that it was low progesterone because progesterone is a precursor to the production of the hormone testosterone. So low progesterone could be the contributing factor. What about bone loss? You know, some of the issues or symptoms that are really concerning for women that are over the age of 50. For all of us, one of them would be certainly bone loss. We don't want to see our bones diminish as we age. Here is a chart that shows that we reach peak bone mass somewhere between 25 and 30. Our bone mass levels out. We see a slight drop in bone density in our perimenopause. And that's when the ovaries stop producing as much estrogen, and progesterone production drops really low. And to a certain extent, this drop in drop in bone loss is normal. Now, what we see here, excuse me, is this was taken from an organization that was promoting hormone replacement therapy. And they were suggesting that if we don't increase our hormones at this juncture, that our bones are all going to decline. Excuse me. Now, Dr. Pryor did not believe that. She believed that our bone density would continue with a smaller amount of estrogen and progesterone that was produced by our body fat, excuse me, perhaps supplementing with a little bit of progesterone only. Now, what I see happening here is at menopause, we can supplement with a bit of progesterone, again, because progesterone is the bone positive or bone producing hormone, and we don't want to supplement with estrogen, and I'll tell you why. Here we have the function of bone. Bone remodels on an ongoing basis, and there's two functions that take place. You see these little brown guys? They're eating away a place in the bone where the little pink guys can live and produce more bone. This is called resorption. Bone has to be resorbed or broken down to make way for new bone. Now, let's talk about estrogen and progesterone. What is the role when it comes to manufacture or remodeling of bone? Well, estrogen stimulates osteoclast activity, or in other words, it stimulates bone resorption. Now, if our estrogen is normal, we'll be resorbing or breaking down old bone at a normal rate. If our estrogen levels fall too low, then our body does not function correctly, and very little bone resorption takes place. However, if we prescribe estrogen, it will increase the amount of resorption at too high a rate. And most HRT escalates estrogen beyond what it should normally be for that woman at her age and stage. And so what we're seeing is the slowing up of the breaking down of bone too much, and we're having brittle bones because there's no place to put new bone. Now, the little pink guys are the osteoblasts, and they're responsible for building up new bone, and the hormone that influences osteoblasts is progesterone. So we have estrogen slowing up the breaking down of old bone. We have progesterone that's building up new bone. With women who were put on estrogen alone, we saw that they had brittle bones. It didn't help because they didn't have the component to build new bone. We need both hormones of balance, estrogen to cause resorption, and we need progesterone to stimulate osteoblast activity. So giving one woman or maintaining hormonal balance is going to help us prevent our bones from being problematic. Let's talk about thyroid and thyroid function. I think that probably one of the most problematic areas for women, and maybe the most underdiagnosed area, is in the area of a low-functioning thyroid. If you answer yes to even 3 of these questions, it's likely that your thyroid is underfunctioning. Now, I think of at different ages and stages in our lives, that that we can experience low functioning thyroid, for instance, PMS. Now, as a menopausal woman, other things will take its place. But recognize that these are symptoms of a low functioning thyroid. If you take these symptoms to your doctor, what they will do is they will suggest that you have a TSH test. Now, a TSH test is basically just testing whether the pituitary is sending the right signal to the thyroid. And based on the TSH test, the doctor will prescribe a Synthroid if your TSH test is too high. If the TSH is too high, it tells the doctor that your thyroid is working too hard trying to produce T4. And so let's give it some T4 and help it along. Well, T4, or Synthroid, or levothyroxine, is an inactive substance. The actual active substance that works in the cells is T3. So T4 has to then convert to T3. Now, the physicians that prescribe this, they just assume that this is happening on a regular basis, that T4 is converting to T3. They're assuming that. Well, we now know that iodine is necessary to help the body convert T4 to T3. What we also know is that in the 1920s, the Canadian government and the U.S. government decided, because there was what was called a goiter belt between the two countries, an area where low functioning thyroid was evident because thyroids were enlarging. So they decided to iodize salt. And it was basically to accommodate one area of the country. Well, in iodizing salt, they put a little bit of iodine, just enough to cause a shrinking of the thyroid so it would go back down to its normal size. It was not necessarily enough to be utilized by the whole body. And so we are finding that women today are deficient in iodine. And so if they're given Synthroid, they're not able to properly convert that Synthroid T4 to T3. And so they still feel the same negative symptoms that they had originally. They still feel the fatigue. They feel the difficulty losing weight. They develop and still have cold hands and cold feet. Their hair is falling out, brain fog, etc. In other words, without enough iodine, the T4 is not being actively taken into the cells. So when a doctor does that test, he's looking for a normal TSH test range of 0.35 to 5.35. Well, they've lowered that a little bit, so now it's from 0.35 to 0.2. At least the integrative medicine practitioners are looking at 0.2. Anything above 0.2 is considered to be problematic. And if you've had, well, if you haven't had a thyroid test recently, you should. If you have had a thyroid test recently, ask them to test your T4 and T3 numbers if the TSH consistently comes out within the normal range. But remember, normal is very wide. 0.35 to 5.35 in Canada, 0.35 to, I think it's 3 in the United States. So very broad range, may not still tell you. We look at anything above 2 as being problematic. Look at the symptoms now and how similar they are. These are symptoms of low iodine. So if iodine is insufficient, you know, same things, fatigue, reduced cognition, constipation, low libido, slow pulse, brittle hairy nails, fibrocystic breast disease. Now, T3 is needed for fat loss, to protect our heartbeat irregularities, for mood, for energy, for cholesterol regulation, and there is no question that deficiency of iodine will lead to a D3 deficiency as well. There is a further reason for hormonally challenged women to kind of focus in on iodine, and that's because there's lots of evidence to support that iodine has a positive impact on our breasts, and that if we are iodine deficient, that we will be subjected to more things going wrong with our breast tissue. And if you look at what iodine accomplishes in the breast, it desensitizes estrogen receptors in the breast. That's needed because of all the estrogen in our world. We don't want it congregating in the receptor sites in our breast. It reduces estrogen production in overactive ovaries. And that's necessary for young women as well. So we want to see the 20, 30s, and 40-year-old women taking tests to see what their iodine levels are. It reduces fibrocystic breast disease, which often precedes breast cancer. And we have, what we tend to see is fibrocystic breast disease in familial situations. So it is a bit of a genetic predisposition to it, but we've also seen it resolve under the influence of improving iodine stores. How do we test for iodine insufficiency? It's an easy test. It's a simple 24-hour urine test that you can take to determine if you have sufficient iodine levels. If anyone on this call elects to order an iodine test, and you can order it from Helpful Hormones, one of our consultants would be glad to spend some time reviewing your test results with you so that you will understand the next step. And iodine is inexpensive. If you are deficient in a little iodine, the tablet is no bigger than my baby fingernail, and it's inexpensive, less than $10 a month to use. So it should not be, in this case, a deficiency because of money. But again, by taking the test, you find out exactly what your starting point is. It also, the lab tells you what dose that you should start on to begin with. So we believe in definitely doing a test. So here we have symptoms: PMS, foggy thinking, irritability, memory loss, fibrocystic breast disease, uterine fibroids, ovarian cysts, depression, decreased sex drive, bone loss or osteoporosis, osteopenia, thyroid dysfunction. All of these, and there are many more, but these are ones that I've targeted, are symptoms that are connected to estrogen dominance. How can you know you're estrogen dominant? Well, if you can see some of these symptoms happening in your life. And then you probably are wondering, well, why is this happening to me? What caused this? Certainly, insufficient production of progesterone would be one. Your body, for some reason, stops the production of progesterone. Dr. Lee and Dr. Pryor and those in research are not sure why the body isn't continuing to produce enough. But one of the reasons is going to be stress. We encounter stress in our lifestyle way greater than our mothers and our grandmothers did. The second reason is going to be that our body is overproducing estrone and estradiol, and estrone becoming estradiol is what happens. Well, estrone is produced in our body fat. So women that are extremely overweight, more than 10 to 15 pounds, could be overproducing estrogen, and we've seen this in testing. Insulin resistance, eating too many carbohydrates that convert very quickly to sugar, eating a diet that's not high enough in fiber, we'll talk about that in a little while, stimulates the body to overproduce insulin. And in doing that, it stimulates the body to produce too much testosterone, which can convert under the influence of aromatase enzymes to estrogen. Stress, we mentioned, lack of phytonutrients, lack of fiber in the diet, not eating a good balance of carbs that are high in fiber. Certainly chemicals and pollutants will be a factor. There's no question that we live in a world that is a sea of estrogen. And truthfully, the synthetic estrogens that are found in hormone replacement and in birth control pills ultimately leave a woman's body and they go into our sewer system, which feeds our waterways and so on. And so we are truly living in a polluted world of synthetic hormones, aside from taking conventional hormone replacement therapy and embarking on birth control pills. So if we were to go to a physician, what would they be offering us to balance our hormones? Well, first of all, the term balance is unknown to them. And secondly, they only really have three things to offer us. They offer us straight estrogen. They offer us HRT, which is a synthetic estrogen with a synthetic progesterone. and it could be a bioidentical estrogen with a synthetic progesterone. They offer us birth control pills, which are basically hormonal in nature and actually contain similar and identical hormones to HRT. Estrogen alone was given to women who both had a uterus and didn't have a uterus for a long time. And the studies after 25 years showed that giving estrogen alone to a woman who had a uterus increased her risk for cancer. And so in 1975, they stopped giving straight estrogen to women with uteruses. HRT was then put together, and they didn't use natural hormones at the time because they couldn't put a patent on them, so they selected Premarin, although it's natural to horses, is not to humans, and they selected MPA, medroxyprogesterone acetate. Basically, they took the progesterone molecule that was normal and natural, and they changed it a few times in a lab so that they could put a patent on it, and that became HRT. And the study that came out in July 2002 said that the risks outweighed the benefits for HRT, and I'll share a little bit more on that later. And then the birth control pill came out in 1960. The first pill had 5 milligrams of estrogen per dose. Today, I think the low-dose pills are around 2.5 or 3. But there's no question that birth control pills still are problematic. We'll talk about why. But some other things just to note. Estrogen was found in the urine of women in only 1920. So, you know, the information we have on sex steroid hormones doesn't go beyond 100 years. Progesterone got its name in 1929. Bioidentical hormones were first made in 1939. Of course, they weren't brought into the public because bioidentical hormones were not patentable. They patented equine estrogen. That became Premarin. Dr. Robert Wilson wrote a book called Feminine Forever, in which he touted that women would become dried up old prunes if they didn't increase their estrogen level as they aged. He couldn't have been further from the truth. So they were giving women estrogen only, and it became linked to endometrial cancer. 6 million women were using Premarin at the time. In 1975, when they shut that down and stopped giving women estrogen alone. They then, 20 years later or 15 years later, developed a synthetic progestin that was patentable that they used in place of what we would use as progesterone today. Micronized progesterone, bioidentical progesterone, was approved in the U.S. and in Europe in 1988. And to this day, it's still not really actively used to oppose estrogen in any formula. But in 1993, they proposed the Women's Health Initiative study. Now, this is a really interesting study because it began because the manufacturers of these hormones, Premarin and Provera, were absolutely assured and convinced that this was helping women's hormones. The trial was halted 3 years early because of the increased risk. And the risks are interesting in and of themselves. The estrogen alone arm was also halted due to the increased risk for stroke and dementia and heart attacks and breast cancer, all of it. And I guess the question everyone on the call tonight should ask is, where do we go from here? Well, the Women's Health Initiative study, I think, showed us a lot, and I don't think that we should demean that study at all. Remember, it was a study of healthy women. The study was stopped 2 years earlier. The risks outweighed the benefits. And let's look at what the study resulted in. A 41% increase in stroke for women who had no risk, because the women with the risks, remember these were healthy women, the women with the risks for stroke or heart attack or blood clots or cancer were removed from the study before it started. So this 40% increase in stroke was for women who had no risk. A 29% increase in heart attacks for women who had no risk. The number of blood clots doubled for, again, women who had no risk. And the straw that broke the camel's back and caused the study to be stopped 2 years early was the risk for breast cancer became 26%. Now, when we look at the risk factors for coronary heart disease and stroke, I'm appalled because many of us were given hormone replacement therapy to prevent heart disease. I was offered it by my physician, And the reason is because my mom has had 5 heart attacks. He said, Jackie, you're at risk. You should consider hormone replacement therapy. My comment to that was, why would I ever do that, first of all? I don't even take aspirin. How long would I have to stay on this? And he said, the rest of your life. Well, in July 2002, this study showed that taking hormone replacement therapy for coronary heart disease was a no-no. It was, in fact, a contributing factor to heart disease. So what was the problem with Premarin and Provera? Well, Premarin was horse's urine. And again, it was estrogen that was too potent for our body. It was, you know, found in a horse and natural to a horse. And a lot of people will say Premarin's natural. It is. But we have to be careful with these terms now. My friend Dr. Alvin Peddle, who's an OBGYN in Toronto, says if you were going to run 7 furlongs or 6 furlongs at Woodbine Racetrack, it might be a good hormone for you. But since we're not likely any of us up for that, it's probably the wrong hormone. A bioidentical estrogen and probably using E3 estrogen would be a better choice for us if we needed it at all. Provera, on the other hand, is more than likely the villain because it has all the side effects, 150 side effects listed. So it is a synthetic progesterone that comes into the progesterone receptor sites and blocks a receptor from the actual production of properly produced progesterone. What about the birth control pill? What's the problem? Well, again, all birth control pills contain similar or identical hormones to HRT, only in larger amounts. All birth control pills work by stopping ovulation. If you think back, when we stop ovulation, we stop the production of progesterone. So all birth control pills stop the production of progesterone. Now, by virtue of that mechanism, it is impossible for the birth control pill to balance hormones. When a woman is on the birth control pill, basically she has a breakthrough bleed. She does no longer have a cycle. Now, in addition to that, birth control pills have no therapeutic benefit that outweighs the risks. Look at the risks. Decreased libido, stroke, depression, migraine headaches, and breast cancer. So, you know, if we look at any of those risks, I don't believe that a birth control method should be a risk for stroke. I don't think it should cause depression. And yet, how many women do we know are on the birth control pill and they've been on it for a little while and they're also on an antidepressant? And they don't realize that their birth control pill or their birth control choice is causing that. The same with migraine headaches. And the risk for breast cancer cannot be denied. Dr. Lee said that there is a 600 times risk for breast cancer for women who use birth control pills between the age of 14 and 21. That's a significant risk as well. Why would that risk happen? Because again, the birth control pill suppresses progesterone production in young women, allowing estrogen to reign supreme. There's always a good reason behind this, a mechanism. All right, so now let's talk about the solution. We've talked about the problem enough. Most of us, I hope, have seen ourselves in this picture. So what can we do about it? How can we balance our hormones and get rid of estrogen dominance? Well, I believe that it's important for us to become educated. You know, education is the key to our power. Certainly we have a DVD to watch. This webinar is excellent. There are good books to read. We have a book list. If you want to email me and at helpforhormones.com, I would be glad to send you a book list where you could begin to read and become empowered. Dr. David on buildingstrengthwebinars.com has a section of all my webinars, and you can order them and just begin to watch them and become informed. I think that doing a saliva test as a personal way of evaluating and as a personal way of monitoring your hormones is a gift to us. Evaluation of hormones is new within the last decade and a half. It's taking on more and more of a life of its own. More and more people are hearing about saliva testing. But I think that saliva testing is a gift to women so that they are able to monitor their own hormone levels and to monitor their own programs. Dr. Jay Mead is a medical doctor in charge of Laverick's clinical. And his comment is, with saliva, it's possible to get a good measure of the amount of hormone that's actually available to the tissues. We term that bioavailable. This is because hormones must pass through the tissue to get into saliva. Hormones in blood are often bound to protein and may or may not be available to tissue. In fact, less than 1% is available to tissues in blood. So consequently, blood or serum levels of hormones may not give the best picture of how hormones are behaving at the tissue level. I have talked to many women who have had their blood tested, if they're able to actually get that done, and their doctors tell them they're fine. The saliva test, then, what Dr. Mead is saying, tests only the hormones that are available to receptor sites. And remember, a saliva test can be given to a teenager, a 20-year-old, a 30-year-old, a 40-year-old, a 50-year-old, and you don't need a requisition from a physician. So if you're concerned about your own hormone levels, we think a saliva test is the way to go. Now, why specifically? Well, if you've been looking at the symptoms list and estrogen dominance, for instance, and you think that there's a possibility that it could be hormonal, it can be validated with a saliva test. If you have been diagnosed with osteoporosis, or if you have a relative who has had osteoporosis, determining whether or not your estrogen and progesterone are adequate is important. Are you in need of a balancing program? Excuse me. We at Help for Hormones will not help anyone until they do a saliva test first. We really feel that we're not seers. We can't project what your hormones really are, and it's important to have a baseline, a beginning point of what your hormones are doing. Now, if you happen to be on this call and you're on a current hormone replacement therapy using bioidentical hormones, the only way to evaluate that is with a saliva test. If you try to get a blood test from your doctor, bioidentical hormones do not show up in a blood test. So monitoring any bioidentical hormone program becomes important by using a saliva test. Now, men too can help to determine their risk for prostate disease. If they are in andropause, a saliva test will reveal that. If stress is a factor that is affecting their hormones, it will evaluate that too. But again, I'll talk more about that on the 31st. So what hormones do I test? We have 3 test kits available. A 2-panel test kit tests E2 estrogen and progesterone. Just 2 hormones once. And that really is a test kit that tests for estrogen dominance. A 3-panel test kit tests the estradiol and progesterone as well as testosterone. And this would be an important panel for a woman who is concerned about osteoporosis. Basically, you want to see all 3 of these hormones, estrogen, progesterone, and testosterone, all in the adequate range in order for your body to be able to produce good quality bone. A 5-panel test is used if stress could be a factor. So adding AM cortisol, which is the hormone that makes you feel like you want to get up in the morning, and DHEA would be important to evaluate whether stress is having an impact on your hormone levels. It's really easy to test. Basically, we have 4 small tubes in the test kit, and you spit just a little bit before breakfast, before lunch, before dinner, before bedtime. You mail the samples off to the lab. The results are emailed to you within 7 days of receipt of the sample. So the lab has to have it anywhere from 3 to 7 days. And basically, we're offering anyone who orders a test kit from Help for Hormones from this webinar, we would be only too glad to review your test results. One of our consultants would do that. Well, what do you do with your test results? Well, we would encourage you to begin a program. And often women want to know, well, what's the next step? I have my saliva test results. What's the next step? Dr. Lee said that the solution to balancing hormones was to take a 2-pronged approach. Basically, his idea was to balance estrogens If they're fluctuating, then settle them down, modulate them. And it is primarily fluctuating estrogens that cause hot flashes, for instance. When estrogen's high, it drops down and goes up again. That causes a hot flash. So it's not low levels of estrogen and it's not high, but it's estrogen that's fluctuating. So stabilizing or modulating estrogen becomes real important for those women. Balancing with progesterone becomes the other arm of the solution. And I know that lots of women out there believe that progesterone is the be-all and the end-all, but I can assure you, without balancing estrogen, you're not going to get the sort of the response that you want from progesterone. You have to work on both sides of this program. Well, I'll give you an example. If you're sitting in a room right now, look at the ceiling. If your estrogen's up there and your progesterone's at the floor, and you bring your estrogen up to where you're sitting in your chair, what have you done for your estrogen? You bring your progesterone up, but your estrogen is still high. And that's the impact that Dr. Lee made. He said, we need to work on both fields. You want to bring your estrogen down, stop it from fluctuating. You want to bring your progesterone up into the area where it needs to be and where it will be effective. So let's talk about progesterone first. Dr. Lee had criteria for progesterone. He suggested 400 to 500 milligrams of USP grade progesterone per ounce. He also suggested somewhere between a 20 and a 40 milligram dose, always divided morning and evening. He always suggested to place it in the area on your body where the skin was thinnest, and he also suggested rotating it in areas so that you didn't block pores. He suggested cycling it even for those who didn't have a cycle, always taking 1 week off, and that would be for men and for women who are using progesterone. For women, they would use progesterone only in the last half of their cycle, in the last, say, 11 or 12 days of their menstrual cycle after they've ovulated. Now, we have really good handouts. When we work with women, we have 3 sets of handouts on how to use progesterone, how to use it well. And we think that if anyone on the call is purchasing a progesterone cream, make sure that they give you enough education. Bioidentical progesterone is a hormone, and you want to know how to use it effectively. If you are using a progesterone cream, you want to be testing every year, making sure that your estrogen is where it should be and making sure that you're not overdoing the progesterone. Dr. Katerina Dalton, OBGYN in London, England, used progesterone for more than 50 years. And her comment was, we can use progesterone instead of estrogen replacement therapy. Women don't need estrogen. Progesterone alone will do it, was her answer. And she said, what is interesting, if we look at menopause being the last ever menstruation, on the average we say it takes 5 years to get to that place. She says 2 years, first of all, we don't ovulate, then menstruation becomes irregular, and then we stop having a period. We stop menstruating. Then we gradually have this reduction. The uterus becomes smaller, the breast becomes saggier, etc. So she reckons that that takes 5 years. Now she says the first thing that happens involves ovulation, which involves progesterone. In other words, progesterone levels drop. So approximately 2 years before actual menstruation stops, we'll see PMS come back. And I hear this consistently with women. So she says, right at that point, I like to put them on progesterone. And then they'll never need estrogen. And that is what we're seeing as well. I personally started on progesterone at 47. I was in what she calls perimenopause, and my perimenopause didn't last 5 years. It resolved itself, and I sailed through menopause. And we would want that for every woman who's listening to this call. Ultimately, every woman on this call will go through menopause if she hasn't already. Progesterone in women, what's it going to do for me? Well, it helps prevent cancer of the uterus. I still personally have a uterus, and so that's important to me. It protects my breasts against breast cancer because it opposes estrogen. Again, that's important to me. I have 2 breasts still. It protects against fibrocystic breast disease. That's important to me. That seems to be in our family. It increases bone density. That's important to me. And we've seen a 12%, almost right across the board, increase in bone density and it stops the decrease in bone at menopause. The normal 5% drop in bone density that we normally would see at menopause really brings that to a halt. And so we're seeing bone density issues resolve and an actual increase in bone density. It maintains uterine lining, prevents endometriosis, hydrates and oxygenates the skin, and this is just a few things of what progesterone does. I haven't talked about what it does in the brain, in the arteries, etc. I give my mom, who's 92 years old, progesterone. She takes a little bit every day. My mom is sharp as a tack. She still functions fully on her own. And Dr. Lee said elderly women who were content to just lie in bed all day and couldn't keep track of conversation or whatever, after a week of being on progesterone, they're up leading discussions on the headlines and the latest in book reviews. He noticed the dramatic effect that progesterone has on the brain. Aside from the fact that elderly women should use progesterone for osteoporosis prevention as a part of their program. So what does progesterone do? Well, the two most prevalent menopausal symptoms, hot flushes and vaginal dryness, quickly disappear with applications of progesterone. Dr. Taylor, who is an OB-GYN, says studies have shown that natural progesterone applied to the skin will alleviate menopausal symptoms in 83% of women. And we have personally seen this happen as well. So it helps with balancing out testosterone, so it reverses that facial hair growth and hair thinning, helps to eliminate depression and anxiety because it builds up those receptors in the brain. It encourages fat burning and the use of stored fat. It normalizes blood clotting. It's a precursor to other important sex and stress hormones like testosterone and cortisol, and it is the hormone that increases libido. It doesn't get any better than that, does it? All right, Dr. Lee said, however, when we are using hormones, and progesterone is a hormone, we need to know these three things. Number one, you only use hormones if you know that you are truly deficient. So that means getting a saliva test. Number two, only then use bioidentical hormones if your saliva test shows that you need them. And number three, only use doses that match what you would normally find in the tissues of your body. In other words, more hormones are not better. In the case of progesterone, we know that the body normally makes about 20 milligrams. Dr. Lee advised dosing for the menopausal woman 20 milligrams in a divided dose, 10 and 10. So you want to be able to determine how much is a 20 milligram dose from the product that you're using. Let's go to the other side of the page now and look at how do we modulate and stabilize estrogen. Well, it's always going to start with nutrition. Here's what we know about nutrition. If we feed our bodies correctly, our bodies will produce the appropriate amounts of hormones. And we know from women who are anorexic that when we withdraw and do not eat correctly, the first thing that stops is the menstrual cycle. So we understand that eating correctly becomes very important. So eating 40-30-30 is, that's the zone. Dr. Barry Sears talks about that. This is, we're recommending another book by a couple that worked with Dr. Sears because this is an easy to read book. Basically, eating 40-30-30 is eating 40% carbs, 30% protein, and 30% essential fats. And it means taking a snack and making it 40-30, or taking a meal and making it 40-30-30. And the 40% carbs, basically carbs, all carbs, are vegetables, fruit, and whole grains. Those carbs all convert to sugar very quickly in the body. So in doing that, it raises our insulin levels, spikes our insulin. So we want to be careful about the carbs that we're eating. Proteins and fats don't raise blood sugar levels in the same way as carbs do. So they are considered better in protecting us from insulin resistance. Carbs are considered good or bad based on the amount of fiber that is in them. So what I usually tell individuals is make sure that the vegetables, fruit, and whole grains that you're eating, number one, are the highest fiber intake. And so make the choices being the highest fiber. What that does is that will help you prevent, ultimately, insulin resistance, which could lead to diabetes. Now, if you're already a person on the call who's at risk, then you need to kick this into gear ASAP. But no question, all of us should start by eating 40-30-30. Second thing we need to do is to increase our fiber intake. And I'm suggesting this now to virtually everybody. Get your fiber intake up to 30 to 50 grams a day. Approximately 10 to 15 grams of fiber in each meal, breakfast, lunch, and dinner. In doing this, you're going to slow up the absorption of sugar, first of all, and you're going to slow up the spike in insulin. And so, to some extent, we want to prevent insulin resistance with this. Insulin resistance will cause a stimulation in the production of testosterone. So we're seeing women with very high testosterone levels simply because they're eating too many foods that are spiking their blood sugar. This is a way to stop it. Increase your fiber intake. Now, you know, if you want a recommendation for a fiber supplement to take that we've used very successfully, taking a teaspoon of fiber before breakfast, lunch, and dinner has proven to be very, very helpful in stabilizing and modulating estrogen. And there's science behind it. The higher intake of dietary fiber, it's associated with lower circulating estrogen. And I think that we need to be aware that what we put into our body has a connection to hormones dramatically. But fiber is step one. Step two is increasing the amount of water you're consuming and increasing your exercise. And the reason for fiber, water, and exercise under this category is because they are a part of our eliminatory process. If we have too much estrogen, if we have too much testosterone, if we're taking in too many synthetic hormones through our environment, the way to get rid of them is through the 3 eliminative pathways. And we're looking at them here. Fiber will affect the bowel. Water will affect the kidneys. And exercise affects perspiration. So again, we have to exercise until we perspire to kick that one in. But recognizing having all 3 eliminative pathways functioning at a high level will help us hormonally. Next, we want to increase our vitamin C. Now, this is primarily to support our adrenal glands. When our adrenal glands become fatigued, we tend to see very low morning cortisol levels. And these are people who don't feel like getting up in the morning. Their adrenals are so low ebb. We tend not to see the women who have high cortisol in the morning. And that is because we're seeing women primarily, by the time they come to us, their adrenals are in the process of burning out. Dr. James Wilson has written a book called Adrenal Fatigue. Excellent book, but this is what he says. When people are under stress or experiencing adrenal fatigue, their body's need for vitamin C increases dramatically. When delivered in an ascorbate form, it's one of the easiest forms for the body to assimilate and use. We've created a specific vitamin C for this use. Most vitamin Cs are ascorbic acid. They're not ascorbate and they're not buffered. And you know, the amount that he's talking about is going to likely be about the same as what Dr. David Brownstein recommends, and that's about 3 grams of vitamin C per day for hormonally challenged women. And we're finding that some hormonally challenged women even need more. The next thing that we want to look at is increasing our indoles. Indole 3-carbinol is the active ingredient in cruciferous vegetables, broccoli, cauliflower, cabbage, and kale. And we've seen lots of studies over the years on this group of vegetables. They're high in antioxidants. They have sulforaphanes in them that help our body. But we're looking at the carbinols, indole 3-carbinols that are involved in this particular product. They have a profound effect on hormones. They help our body eliminate estrogen. Now, this is one way to stabilize your estrogen and to make sure that E1 estrogen converts to E2 estrogen and is properly eliminated in the body. How much do you have to eat of cruciferous vegetables? Well, the studies show that you needed 2 pounds a day at the least. Most of us would eat a serving, maybe not even once a day, 3 times a week. And so we, again, created a supplement that supplements 2 full servings of cruciferous vegetables, assuming that we're going to eat 1 every day. But there is no question that indole 3-carbinol has lots of research as it affects estrogen levels in both men and women, by the way. And it helps the body to detox and get rid of too much estrogen. It causes it to move in the direction it should. Next is to use a fruit and vegetable concentrate to compensate for the nutritional gaps in the diet. One of the things that we're seeing scientifically is that when women eat more fruit and more vegetables, it lowers their risk of disease. And particularly, we're looking at breast cancer risk factors here. A breast cancer risk factor that gets lowered because of consumption of good nutrition tells us that good nutrition is affecting the hormone levels. And so we produced a supplement that contains the equivalent to 17 forms of fruit and 17 forms of vegetables because we know that women are probably not going to eat from that wide a variety normally, and we're just not eating enough of them. Use a moderate amount of calcium, preferably plant-based, and increase vitamin D3. If you listen to Dr. Dougal on his presentation on vitamin D3, he really believes that we don't need more than 250 milligrams of calcium. And I would tend to agree with that. He suggests also that what we do need is an increase in vitamin D3. We've been doing vitamin D3 testing, and we've come to the conclusion that the majority of us are D3 insufficient. We need vitamin D3 to absorb the calcium in the foods that we eat, and so it becomes real important for us to make sure that we get an adequate amount of D3. Dr. Lee's position on calcium was that we could eat probably 1,000 milligrams of calcium in the diet, not supplementing. And there's actually been research that shows that women that supplement 1,000 to 1,500 milligrams are at higher risk for kidney stones and bone spurs because that calcium is not being deposited properly because of a lack of D3 for one, and because of overconsumption and probably taking in the wrong forms. We've actually created a calcium from plant source that is much more bioavailable. And of course we are supportive of increasing our vitamin D3 stores. And the reason D3 becomes important, D3 is now being considered a hormone. And as Dr. Northrup says, there's a paradigm shift going on in the medical field. And, you know, research is revealing that, you know, a far greater role for vitamin D is coming into the forefront. 5 years ago, the range was 20 to 100 nanograms per mil. That was considered normal. Now we're looking at probably 80 to 100. She suggests raised to 32, but I'm suggesting that in some of the medical circles we're seeing they want to see 80 nanograms per mil in order to see sufficiency for vitamin D. Vitamin D3 is a natural human form. Vitamin D is made in the skin when you're out in the sun, and it is cholesterol that reacts to the sun. So you need cholesterol to make vitamin D. If you don't have enough cholesterol in your body, you won't make vitamin D either. And vitamin D2 is not vitamin D. I was in Costco the other day looking around, and I saw D2 on a number of their supplements. Don't use it. It's not effective. And if you want to know more, I did a webinar on D3. All you ever need to know about vitamin D in that webinar. So the levels, such as 400 to 800 IUs, have not proven successful, according to Cedric Garland. Now, he's in a research group that's researching vitamin D. He's part of the Vitamin D3 Council. And very excellent information if you want to have a look at that. So if you test D deficient, the patients for breast cancer, if you test them for D receptors, they probably don't have many, he says. But as soon as you give them vitamin D, the body makes the receptors right away. And so that's an important thing to note, that your body's health can be improved by adding vitamin D. I agree, latitude counts. If you look at the map, anywhere north or above Los Angeles to Colombia, we're probably deficient. We don't get enough sun, we don't expose our bodies enough, and so deficiency of vitamin D seems to be the norm. Breast cancer patients with low vitamin D levels had a 73% higher risk of death than women who were vitamin D sufficient. And there's lots of breast cancer studies out there on vitamin D3. Here's another one. Breast cancer risk was reduced by 50% by increasing vitamin D. And these folks only took in a small amount. How do you test for vitamin D3? It's very easy. We have test kits available, and we really believe to test and not guess. But Dr. Northup encourages all women to check their vitamin D levels. In Canada, we know that vitamin D was able to be tested under their government's provision, but that has changed, and no longer are Canadians able to get vitamin D3 testing for free. So I'm traveling around the country and encouraging women to at least do a test. Coming up now, we're getting to the place in our in the spring, close enough to the spring, that we're probably, most of us are very deficient. Where should we be? Well, again, anything above 60, I think 40 to 60, even upwards to 80. Those that I've tested, if they're on our program, they're upwards to 80% or 80 nanograms per mol. In Canada, that's going to be around 200. If you want a copy of this vitamin D status, email me and ask me for our newsletter on vitamin D, or go onto the website and print off the vitamin D3 newsletter, and it has that in it. So let's review. How do you stabilize estrogen? You increase your fiber, increase water and exercise, add more vitamin C in a buffered form, take indoles, make sure you eat a fruit and vegetable concentrate in addition to eating a good quality diet. Make sure that you only moderately supplement with calcium, probably no more than 250 milligrams, and preferably from a plant-based source, and make sure that your D3 intake is adequate. Now, we've produced a pack called the Balance Pack with D3 spray for the purpose of balancing hormones. If you want to have a look at the things that we offer, you can go to maxalive.com and have a look and see what, if anything there interests you. What's our 5-step program again? Step 1 is to do a saliva test. Again, testing, not guessing. Number 2 is to eat the best foods that you can possibly eat. Balance the food, the nutrition program that you're on. For most of you, it's just tweaking what's already there. Number 3 is supplement the difference. If you're not getting enough fiber, if you're not getting enough vitamin C, enough indoles, the right kind of calcium, enough fruit and vegetables, and vitamin D. And we put these supplements together like this in a package because these are the ones that we see people aren't getting enough of. And so we're making them available to help balance hormones. Exercise to maintain testosterone levels, to eliminate fat, to reduce estrogen levels. Eliminative pathway is kicked into place. And then use bioidentical hormones when shown to be deficient on a saliva test. Here's what I believe. If we accept responsibility for the health decisions that we've made in the past and then start to take responsibility for our own current hormone health, I believe only then can we begin to move towards wellness, true wellness. Hormone imbalance, I think, can no longer be accepted as a norm. You know, we as women, at least 30% of us will encounter difficult times with our hormones. I think it's time to remember that it seems that this information has not been taught in medical schools for over a generation. So each of us then becomes responsible to, for every drug, for every surgery that we allow, and for anything that we put into our body. We really do have to take responsibility. I think finding hormonal balance will involve, for everyone on this call, becoming educated first. You know, watching the DVD, watching the webinar over and over again. We put a CD in with our DVD pack so that you could listen over and over until you get it. It will involve doing evaluations, testing, doing saliva testing, iodine testing, vitamin D3 testing, whether your symptoms are rooted in hormonal balance or not. And then embarking on a program. No one, I repeat, no one can turn around any health challenge watching this webinar or even doing a saliva test. It is only as you move out into a program that you actually can create wellness. So we have test kits that are available from Help for Hormones. Our supplement program is available from Max Alive, and I have consultants that would be only too glad to help anybody on the calls with any questions or comments. Again, this is our DVD pack, and it has a CD with it. It has different information than what I presented tonight. There are doctors on it. There are women giving testimony of a program, and I think you'll find the information is inspirational. We are always looking for women to become involved with us, and men as well. And so I invite anyone on this call to consider, if you like what you're hearing tonight, if you want to share and help other people, I would encourage you to consider becoming a Max Alive consultant, or at least, you know, working with us to, you know, to come to some sort of an opinion about whether or not you want to be involved. All right. I thank you all so very much for your attentiveness. What we're going to do now is we're going to move over to some questions. And so in order to do that, I'm just opening up questions here. All right. I love the new slides on the osteoporosis. Well done, Jackie. Thank you very much, Deb. Do you mail to Australia? We absolutely do. Our supplements can be purchased in Australia. Our company ships to Australia, and all of our training is and teachings are available as well. So by all means, if you live in Australia, I'd be glad to work with you. I'm looking for a consultant there. Are there any other questions? All right. What is the role of magnesium in hormonal balance, and do you work in Mexico? You know, I don't have anyone in Mexico at this point in time. The problem is that we mail out our supplement program. We ship it out, and so but I'm sure that we could. I think there is a company that I'm aware of that we might be able to link up with in order to be able to ship conveniently. Let's talk about magnesium. Magnesium certainly has an influence over muscles, and so magnesium's role in the heart has been real important. It also has a role in cramping, and so we always want to make sure that we have an adequate amount of magnesium in the body. So the women who primarily are going to have low magnesium would be PMS. Gals with PMS could take some magnesium. I think that women that are menopausal have a higher risk for heart disease, and so making sure that you have an adequate balance of magnesium for them is important as well. I hope that answers your question. I'm having hot flashes and really awful freezing chills. Will progesterone cream help this? Well, I think that first of all, identifying where your hormones are at. It would be important to identify, do you have low progesterone before you start taking it? It's been my experience that hot flashes result from estrogen levels that are fluctuating. So I would want to know where your estrogen level is too. And so doing a saliva test, at least a 2-panel test, I think would be very important. Now, the freezing cold often has to do with a thyroid connection. But here. All right. Okay, so how do I figure out how much cream to use? It would depend on your product, Lacey. We'll have to, we have lots of directions on how to do that, and I'm more than glad to do that, to help you with that. But I wouldn't be able to know, every progesterone product's a little bit different. All right, I'm a medical doctor and a homeopath, and I would be very interested in working with me. All right, well, let's talk, Rosa. I would love to do that. If you could email me and we'll set up time to visit, I would love to be able to help you. All right, thanks to everyone who liked the new slides. All right, where would I purchase your items? In Melbourne, Australia? They're not available in Melbourne. You'd have to go online and order them online, and we would ship them into Australia. Would the 5-panel test be enough to diagnose adrenal fatigue? Yes, Pam, it would be. And the reason it would be is because what we tend to see is we test morning cortisol only. If your adrenals are fatigued, you won't be able to produce an adequate amount of morning cortisol. That's when cortisol is supposed to be the highest. And so if you're not able to produce enough in the morning, it's going to be low all the way through the day. And that's been the evidence that we find. It rarely comes up. And so I would suggest that you do a 5-panel test, and let's see what your morning cortisol is, and also see what your DHEA level is, because I think that low DHEA will also be significant indicator. All right. Okay. Thanks, Catherine, for your kind words. Could I show the 5 steps slide again? Oh, I'd be glad to. Okay. Let's put it back here. And I'll just see if I can get this. 5 steps. Very important. All right. All right, and you, let's see, other questions. This is fun. I'm doing this myself tonight. Can you test for magnesium levels? I'm pretty sure that naturopathic physicians are able to do that. So get in touch with somebody who is there. I've been using bioidentical progesterone for years. The only thing that doesn't seem to get better is the vaginal dryness. I found that in many of my patients. All right, let's talk about vaginal dryness for just a moment. The majority of women that suffer from vaginal dryness truthfully don't have low estrogen. And we've discovered that through saliva testing. What they do have is low progesterone. And so we created a progesterone cream that can be introduced intravaginally, and it doesn't irritate the vaginal mucosa. Unfortunately, a lot of progesterone creams, their first ingredient is water, and because of that, they have to have a number of drying agents that are primarily alcohol. Using a progesterone cream like that will, intravaginally, will irritate the vaginal mucosa. So using a proper progesterone cream usually will work very well. And what it does is it opens up the receptor sites for estrogen in the vaginal wall, and so it allows the amount of estradiol that's there to get into the receptor sites. So progesterone and estrogen work together, but we can usually resolve most incidences of vaginal dryness with just a little bit of progesterone introduced intravaginally. But again, Rosa, I'd love to visit with you via telephone sometime, so let's do that. If my TSH is 1.9, could I still be low in thyroid? Absolutely. I would ask my doctor for a T3, T4 test. And then you know what, because again, TSH is the signal that is being sent to your thyroid from the brain. It's not actually telling you how much circulating thyroid hormone is in your body. And so knowing how much circulating thyroid hormone is important. Okay, do I need to supplement with another daily vitamin pill, or does Max Alive packet take care of vitamin needs? You know, our Max Alive supplements are made from whole foods, and the Max Alive Daily Max packet was intended to replace a multivitamin. Now, if you, there would be exceptions to that, but it's better than any multivitamin. If you look on the outside of the package, Rosemary, you'll see that it's just chock-a-block full of real food. And we believe that if you're going to have a real food program, you better have real food supplements, not supplements that are made in a chemistry lab. So I believe it will replace your multivitamin. All right, are there any other questions? They seem to have stopped coming in. I think we've probably been at this long enough. The hormonally challenged need a break. Did I miss anybody's question? All right, I think we'll call it a night. Oh, here's another one. Can we do phone consults with you? I don't do phone consults until somebody's done a saliva test with me. But then you're more than welcome to personally talk with me. But I don't just talk about somebody's hormones. I want to actually review a saliva test. So Pam, you're more than welcome to meet with me personally, but let's center it around a saliva test result. So order a test kit from us, and then we'll set up an appointment time. And I answer all my emails as well. So if you want to email me questions and concerns, I try to do that as well. Do we do thyroid testing? No, we don't. The only test that we do, because thyroid testing can be done with a blood test through your doctor, we only do iodine testing, which is thyroid support, basically. My email is helpforhormones@gmail.com, Rosa. helpforhormones@gmail.com. All right, I'm going to say goodnight to everyone. Thank you so very much. I hope to hear you on the 31st. Come on along and enjoy our presentation on men's hormone health, and we'll hope to hear from you then. Take care.